Good morning again. My name is Ungid Buttar. I am the Director of State Engagement here with Shatterproof in our Outlets team. Thank you again for attending our fourth session in our 2021 Continuous Quality Improvement Learning Series. Before we begin our session this morning, just wanted to cover a few quick housekeeping items. First, please remember to keep your lines on mute if you're not speaking. Feel free to enter any questions that you might have in our chat. We have set aside time at the end of the presentation for Q&A. However, you're welcome to ask questions at any time during the presentation. This session also is being recorded and will be sent out to everyone in the coming days. And this will also be posted on our CQI website, treatmentatlas.org/CQI. And lastly, during the webinar, please, as I mentioned earlier, feel free to complete all the poll questions. There's some here at the beginning, and there'll be some at the end of the session as well. So please, we would love your feedback. So I'm really excited to welcome back our esteemed providers from California Bridge, and I'll introduce them momentarily. I said welcome back because, as many of you are aware, the Atlas team and California Bridge recorded a webinar back in August that was sent out as part of the invitation for this event, and also it's posted on our CQI site. So I hope many of you were able to view the webinar, the pre-recorded webinar, and if you haven't already, please view it after today's session. So without further delay, I would like to introduce our guest speakers today. First, Ariana Campbell. She's a director and co-principal investigator with California Bridge. She is the emergency department PA with more than 20 years of clinical expertise informing her work. As an APP lead for the U.S. Acute Care Solutions at Marshall Medical Center in California, Ariana has initiated an innovative program to treat patients with opioid use disorder. And she's also been recognized by leaders in addiction medicine and beyond. And Ariana became a founding clinician of California Bridge, a program of the Public Health Institute. Next, we have Dr. Alicia Micheletrich Gonzalez. She's a clinical consultant. Dr. Gonzalez is a medical director of emergency medicine at Marion Regional Medical Center in Santa Maria, California. She's also the opioid stewardship physician champion for Dignity Health and serves on the board of governors for the American College of Emergency Physicians Pain and Addiction Care in the Emergency Department Hospital Certification Program. Alicia is also the creator and host of the Real Talk podcast, bringing the human experience of healthcare providers to life through storytelling. And last but certainly not least, we have Dr. Alani J, who is faculty at the Sutter Family Medicine Residency Program. Dr. J is a family medicine specialist affiliated with medical facilities Marshall Medical Center and Sutter Santa Rosa Regional Hospital in California. And she was medical director of Marshall Cares Addiction Medicine Clinic and Progress House Inpatient Rehabilitation, and played a pivotal role in developing rapid access patient-centered care for patients from Marshall Medical Center at the beginning of their ED MAP program. So look forward to the presentation here today. At this point, I would like to turn it over to Dr. Gonzalez.
Thank you so much for introducing us. We're pretty stoked to be back here. Hopefully most of you have been able to view that 1-hour webinar that we put together before. We had such a good time, honestly, doing that presentation, and we've loved this collaboration. So we're really excited to be here. What we're about to do is kind of breeze through some of that material that we talked about in a condensed version so that there's no FOMO. Anybody who missed the lecture at least gets the highlights right now. So if you've already watched it and you need to go grab a coffee, we understand. And then we'll open it up for question and answer for any of you, and we'd love to help with whatever those questions are. If you're worried you're going to forget your question, feel free to toss it in the chat in the meantime, and we'll get to all of them, I promise. So this was mentioned before, but we are from the California Bridge program, which is part of the Public Health Institute. Individually, none of us has any financial disclosures. I always make the joke, though, that if one of you would like to pay us, just give us a call. Our emails are at the end. Just joking. We would do this for free. We do this for free. So the main premise of what we're going to talk about, the rest of what we're going to talk about, really hinges on this idea that addiction is not a moral failing. This is the beginning of us really starting to shift culture in our country, thinking about addiction and substance use as a chronic treatable disease. And yes, sometimes we have to acknowledge that when you're using drugs, maybe it's a result of some unfortunate consequences that you made to start using drugs. But that's actually true of a lot of chronic medical issues that we deal with. Let's talk about diabetes, right? People don't eat well and they make bad diet choices. They don't exercise, bad lifestyle choices. And then your body, you become obese and you develop diabetes. Those are also unfortunate consequences of some decisions that you've made, but yet we feel very open to giving metformin or insulin or the appropriate medical treatment to those patients. Same thing for high blood pressure, high cholesterol, obesity in general. There are lots of things that we do as humans that aren't perfect. And when we have science to help back us in improving somebody's lifestyle, we do it. Addiction is the same. People make some unfortunate choices, their body becomes dependent on the drug, and now we have evidence-based ways to take care of those patients and help make their lives better too. The same as everybody else. So we developed out here in California, the California Bridge model, and there are three main pillars of what we believe this means. The first is having low barrier access to medication for addiction treatment, evidence-based treatments for patients when they need it, right out of the clinic or right out of the ER without having to jump through a million hoops. Second is having a warm handoff, a clean connection to the community that's not the same as that 14-page photocopied a million time packet of quote resources, good luck to you, but somebody who actually helps connect the patient to the care that they need when leaving the acute care setting or in the clinic. And then finally, building a culture of harm reduction, fighting stigma and thinking about ways that we can help reduce the consequences like, transmitted diseases, hepatitis, HIV, death from overdose, the things that come along with drug use to be able to help save lives. This is Ariana made this slide, but I love stealing it, which is that overall, we want to make the medication for addiction treatment, access to buprenorphine, a medication we're going to talk about, easier than access to street drugs. So this is something that people talk about a lot is what happens if I prescribe this medicine and it gets diverted? Great. I would much rather that this medication is all over my community than heroin or fentanyl or the drugs that I know are killing my patients. And so that's one of the big premises is making access to treatment easier than access to drugs. To be able to describe what that looks like, Ariana, what do you think about walking us through a patient case?
Sure. So I've been practicing in the emergency department for a really long time. So for 17 years, this is Javier. So Javier, 24-year-old male, uses heroin, says he wants to quit, isn't really sure how. And so he comes to the emergency department. So I have to say, historically, if Javier came to my emergency department, number one, frequently he would not necessarily feel comfortable telling me that he's been using heroin. Because why on earth would you tell somebody something that's really highly stigmatized if you don't think it's actually going to benefit your care and may actually detract from it, right? So what we used to do is Javier would come in, and if we were so fortunate that he would tell us what's going on, frequently he would be pretty sick. He would be very uncomfortable, writhing around. His heart rate may be going fast. He may be dehydrated because he's been vomiting all night. We might start IVs, get a bunch of labs, give him fluids. And then in terms of medication, we'd actually give historically a blood pressure medication that would help him. I know it sounds weird, but it would help a little bit with withdrawal, shaky evidence. And then we would also give him anti-nausea medication. We try to make him comfortable, but we didn't really use medication that was very effective. And frequently when Javier left, if he said, okay, I'm ready to leave, many times Javier would leave against what we call against medical advice and say, this isn't helping me. I'm going to leave because you're not helping me. We would hand Javier a list of facilities. Now we call it the list. It's this list that exists in almost all emergency departments across the country. Mine, embarrassingly, was probably at least 10 years old and had places on it. Almost all of them said, you need to be completely off drugs. So you needed to, like Alicia was saying, in terms of diabetes, it would be listen, you need to go ahead and control your diabetes on your own, before we're ever going to see you. So you need to go completely through withdrawal, and then we will see you and possibly admit you. But we require huge amounts of money up front. You'll have to travel 3 hours from your home. We're going to take your phone and everything from you. Like, there was all of these things where people had to quit jobs. None of it was really patient-centered. And my patients even would come back and tell me, I guess I was supposed to be pregnant. I'm a guy. Like those are the places that I was sending people that were on the list. So, it really wasn't benefiting somebody like Javier, who really needs treatment and finally came in asking for it. So I'm ready for the next slide. What I want to say is, if Javier comes in and his chief complaint is that he is withdrawing from heroin, we are already winning. Meaning Javier felt comfortable enough to tell us that he is in withdrawal. This is pretty easy for us. Like, we love it when somebody tells us what's wrong with them in triage, right? Because so often we are sorting through things. For example, Javier may have come in before. If he didn't feel comfortable telling us he was in withdrawal, his chief complaint may have been diarrhea. Abdominal pain is very, very common. Dehydration. These are certain things that come, where he would come in and not feel comfortable telling us. And all of a sudden we're chasing all of these things and really not giving him medication that works. So when Javier comes in and tells us he's withdrawing, it's a win. We have signage all over RED to tell folks that, to make it comfortable for them to come in, because we want them to feel really comfortable disclosing this to us. And why is this so important? It's because 28% of adult emergency department patients screen positive for a substance use disorder. Our patients are sitting in our lobbies waiting to be seen. And like I said, more than a quarter of them have a substance use disorder that they're struggling with. So when we provide signage, when we help folks feel comfortable telling us about their substance use disorder, we're creating an avenue for them to get the help they need. And there's these periods of time where folks are more open to treatment, and we find that's very frequently the case in emergency departments. And with this next slide, why is this such an emergency? I can tell you, when I was in training, I was told that opioid withdrawal was not an emergency, which is so not true. So this is a study. Out of Massachusetts from Scott Weiner, and this talks about the risk of patients dying after they come to the emergency department after a non-fatal overdose. So these are folks whose overdose was reversed, and they come into the emergency department, and sometimes they leave because they're uncomfortable, maybe against medical advice, or they are discharged from the emergency department. And what this illustrates is the risk of death within the first couple of days. So of all of the patients who come in with a non-fatal overdose, so we reverse them, save their life, 5.5% of them are still going to die in that first year. And of those patients, 20% are going to die in the first month from a repeat overdose. And of those patients, 22% of them in those first couple of days. And I can tell you, there's no other medical problem with this high of risk that we would feel comfortable sending out the door without appropriate medication. And that appropriate medication is buprenorphine, which is what we now give in our emergency department. So why do we give buprenorphine? Well, there's a study from Gail D'Onofrio out of Yale that was published in JAMA in 2015, where she was able to demonstrate that by giving the right medication at the right time to the right patient, we can double that patient's likelihood of being in treatment in 1 month. So we can give this life-saving medication that's absorbed sublingually. So it's absorbed under their tongue. We don't need IVs, we don't need labs, we don't need urine. All we need is to give them the right medication at the right time. I will frequently do this very quickly in triage, and this stabilizes the patient and gives them the right medication at the right time to help stabilize them so they can make it to their next step. And this is incredibly important, and this is the entire model. So why do we believe in this so much? Well, with buprenorphine, so in emergency medicine in general, we're pretty simplistic. We love the simple number needed to treat. And we look at the number needed to treat for so many medical conditions, and it just gives us one number which we can feel good about. So, Alicia, we give aspirin all the time when somebody comes in with chest pain, right? So 42 patients to save a life. So we're giving blood thinners when people have an irregular heartbeat. That's standard of care. So 25 patients need to be treated to prevent a stroke. So we can go down this list, and what we find is we only need to give buprenorphine to two patients to retain in treatment. So this is a number needed to treat that is incredible. It's a game changer, and it's something that we should be doing in all emergency departments to save lives. And the same medication decreases a person's risk of dying from any cause, if they're maintained on this medication, by more than 50%. So this is a no-brainer. So this is something that we should be doing in all emergency departments. And in California, we've very rapidly implemented a program to do this. So we were able to treat a really large number of patients in a short period of time by keeping it really simple. Again, giving the right medication at the right time to the right person. And so we have substance use navigators, which I'll talk a little bit about. But in this period of time of just a couple of years, our substance use navigators saw more than 66,000 patients, identified more than 42,000 patients with opioid use disorder in the emergency department. And more than half of them, so 23,000, were started on medication. And some of these patients are coming in for a different reason. They might be coming in for an abscess. They might be coming in for various reasons, sometimes some complications from their use disorder. But we are treating them now with the appropriate medication and treating them with kindness and respect. And that is what's really, really key here. So Javier comes in, and so we treated him with buprenorphine, right? So rather than starting all these IVs and labs, Javier felt comfortable telling us that he was using heroin and having a lot of problems with it. We treated him with buprenorphine. It worked. He felt better. He's one of those 23,200 patients, and now he's ready to leave the emergency department feeling better, right? So what do we do now? Well, in California, our model includes navigators. What we did determine is, though the medication is pretty simple, we give really crazy medications in the emergency department, and this is one that's pretty simple to administer. Sometimes getting that follow-up piece, that's what we've heard across California, really across the country. Sometimes that follow-up piece can be tricky. Now, what I can tell you is in 195 sites in California, we have found follow-up for patients. So a place for folks to land when they leave the emergency department. And a lot of this work is done by our substance use navigators, and they're the real game changers. So we have a group of folks who are trained in motivational interviewing. They're trained in how to really talk to patients and engage patients. And then they identify all this siloed stuff that's in the community, like a place maybe where, for example, Dr. J, she's a family practice physician who's very passionate about treating people who use drugs with kindness, respect, and the evidence. You find somebody like Dr. J who says, oh my gosh, yeah, I'll take patients in follow-up. I'll take them the next day, the next business day. I'll hold a time for them. So what it looks like before Javier leaves the emergency department, he's been identified with a substance use disorder. We've provided him the appropriate medication, and our substance use navigator is advocating for this patient the entire time. He's advocating for Javier this entire time and facilitates that follow-up piece. We'll make sure that Javier has transportation. We'll make sure that Javier can make it to that appointment the next day, that the time works for them, that they know where the clinic is, that maybe the pharmacy, all of those pharmacy issues are handled, so that Javier can literally just, the person who's getting treatment can just go to the pharmacy and pick up the medication, and then go to the appointment the next day and feel really good about it. So I know it may sound strange to have to point out that this should be easy, but this should be easy. So we really want Javier to have a good experience, because we want to capture Javier at that one moment when he really had the courage to show up in the emergency department and ask for help. And we want to make sure we have a plan for him, and that we treat him with kindness, respect, evidence-based care, and with a plan. So a discharge plan. So make sure that your staff is equipped to make sure that they can bridge to care, and maybe they can find, I'm lucky that I've had Dr. Lonnie J for so long to send patients to, but make sure that you find resources in your community. We have no addiction psychiatrists in my community, so we rely heavily on family practice physicians who are doing this work and who are providing buprenorphine in follow-up to our patients. So now Javier goes to the clinic, and just like I would normally, I'm going to turn it over to Dr. J.
Thank you, Ariana. So my name is Lonnie J. I'm a family medicine physician, and it's you can see why, when hearing the evidence from Ariana and hearing her excitement for this work, I was, of course, enrolled in this process. My background was starting a family medicine practice in a rural community in El Dorado County in California. And as I opened my practice to start seeing primary care patients, what I saw was a lot of people struggling with substance use disorder coming into clinic. And so early on, Ariana and I were at a meeting trying to think, what do we do here? And so as you can see, it's easy to get enrolled in this work when the evidence is so clear. Just to clarify, I'm no longer affiliated with Marshall Medical Center. I actually am now faculty with the Sutter Family Medicine program, and I'm working in their Amador rural tract to try to bring this work to another rural county significantly needing this. But in my time working with Ariana at Marshall, this was the handoff that was so beautiful. So for a patient, Javier, coming to clinic, a substance use navigator would call us or send us a staff message within our electronic medical record. And a patient would then be in our lab. So the important thing about bridging people to outpatient care is that it needs to be on a patient's terms. So whatever way is the right way for them to engage in care and come into care, we need to have that as an option. So whether it was calling in, whether it was walking in at an unscheduled time, or whether it was next day at 9 a.m., we always kept that appointment open. That was necessary to have a very low barrier for people to come in. So there are a lot of barriers to treatment. When people are struggling with substance use disorder, there are things that we don't realize when our life is stabilized and we have all the social support in our life. We don't realize what it actually feels like to be struggling with barriers, whether it's lack of phone, lack of housing, lack of transportation, whether you're struggling with substances that make it difficult for you to know what time it is, wake up in the morning, show up at a specific time. Those are barriers, and yet people are not going to get better if they can't engage in care. So it's very important that we allow an avenue that people can come in wherever they're at. And it's also very important to not exclude a patient from appropriate treatment with buprenorphine for opioid use disorder because their life is in chaos or they're in active, unstable use. So if people are coming in and they're actively using other substances, if there are stimulants on board, benzodiazepines, alcohol, none of that's a reason that I'm not going to give them buprenorphine. Why would I not at least try to help and try to stabilize and give standard of care treatment for the thing that I can fix in that moment, while also getting them one step closer to working on the rest of this? It's very important to provide the support while they're there in clinic and get them connected to other support pieces in the community. And it's also very important to not make their treatment based on merit. So they don't have to have earned buprenorphine, they get standard of care treatment. So they don't need to leave a urine drug screen for me to be willing to give them buprenorphine. Usually I don't even check that at the first visit because it's not going to change whether I give people buprenorphine or not. I use that later on as an opportunity to see if patients are taking what I'm prescribing and engage where they're at. But the most important thing at that first visit is people know that this is a safe place, that I am interested in building a relationship with them, and that it's okay for them to be in instability because that is what we're there for. So moving on to the next slide. As we talked about, it's important to avoid strict appointment slots and have some flexibility in the way people come in. So with our patient Javier, it's been a week that he's been on buprenorphine, and now we have an opportunity to work on the rest of the parts of his life. And so this medication first, that's sort of the buzz phrase that we're using now, that is the most important, the piece that we're going to stabilize. We're going to make sure people stay out of withdrawal with buprenorphine as our initial approach. All right, next slide. It's important to also have the support pieces in clinic to help people overcome struggles with insurance, have opportunities to treat uninsured patients. So there are grants out there. There are ways that we as healthcare providers in clinic can overcome these barriers, but patients can't do that on their own. They don't have the ability to go get grants to overcome their lack of insurance, and often they can't navigate the complex network of getting insurance. Sometimes not having ID is a barrier, and so they don't have insurance and they qualify for a Medicaid plan, but they don't have ID. All of these things can keep people from standard of care treatment, and when they're dealing with active, chaotic use, they're not going to overcome those barriers on their own. And so that is a wonderful opportunity for us in clinic to help people get insurance, have ways to treat uninsured patients until we can get those support pieces in place. A common barrier actually is getting the medication at the pharmacy. And so some work often needs to be done to work with your pharmacist to let them know what you're doing, to enroll them in your process, so that if you send a prescription over and they don't have that version or there's a problem with it, the patient is not left after clinic hours at the pharmacy not being able to get their medication. The pharmacists in my community know that it is important that my patients get their medication, and so they will call me on my cell phone if there's a barrier at the pharmacy so that patient doesn't leave without the medication they need. And so building that piece so patients aren't left on their own is very important. One very important thing to remember is that medication is stability. Medication is sobriety. And I even sometimes avoid using the word sobriety. I use the same medical words that we use for every other disease process. We have a patient with unstable brain disease that we are stabilizing, and medication is the route towards stabilization. It is not a second hand less than treatment. It is treatment. They are there. If they are stable on medications, we are doing our job. We wouldn't tell somebody that has an A1C that's at goal with the medications we're prescribing that, yeah, your diabetes is well managed, but you didn't do it by starting to run marathons and losing 100 pounds. We would say, great, your A1C is at goal. Let's keep doing what you're doing. Let's also work on these behavioral pieces. But guess what? Right now, your diabetes is not going to kill you. And that is the same approach we need to take for people with substance use disorder, especially opioid use disorder, stabilized on buprenorphine, that we have done a great job, and adding the support pieces is important for their continued journey. But there's a lot of buzz in the field that people are not really clean and sober when they're on buprenorphine, and we need to dispel that myth because it's not helpful. As you can see, relapse rate are similar for people with substance use as with other chronic illnesses. And so putting what's happening to them in context of other chronic diseases is very important for patients to understand, and then for us to understand as providers that relapse is part of this remitting relapsing disease process. And just like with substance use disorder with high blood pressure, your blood pressure can be stabilized. You come into clinic, it's high. We adjust your medications, get you back in range. That is common with substance use disorder as well. And so it is clearly shown, we know now within the medical profession that substance use disorder is a brain disease, and it has roots in your dopamine reward center, which is directly tied to your amygdala, your fight or flight response. And you have a hypofunctional prefrontal cortex. So the front part of your brain that is the decision maker is not working at the same rates. They've done functional MRIs and looked at people that are addicted to substances and those that are not. And we see that the front decision maker part of their brain is hypofunctional. So their reward center is driving the ship. Their fight or flight response, their amygdala is overactive. And so their substance has a position in the hierarchy of their brain where it doesn't belong, that it is in their amygdala next to food and shelter and water and the drive to procreate. The substance is there, and that is what is driving behavior. And we're not going to fix that until we stabilize their dopamine reward center, stabilize their craving with medication for addiction treatment. that will stabilize the brain disease. And then we can work on the behaviors involved, and we can work on getting their decision maker activated so that people make decisions where they have stability in their life and they are able to live their best life possible. So that is the work that we're doing. So we talked about, for patients who return to use, provide additional support rather than stopping their buprenorphine. We would never stop somebody's insulin if they came back and their A1C is at 10. We would never punish them for that situation. We would offer diabetes education. We would adjust their medications. We would want to see them back sooner. Please remember to do the same thing, because if not, we're leaving people with active substance use on their own to try to fix it. And that is an even worse situation than them coming in, having relapsed, having returned to unstable use, where at least we can help. Because if left on their own, that is not standard of care treatment. That's not what we do. All right, so turning it back over to Alicia to talk more about options.
Yeah, so when we started working with Shatterproof and Atlas, one of the things we loved is that we have a lot in common. And what we believe are the tenets of providing quality care in this area. And they're listed on the screen, and we touched on most of them already. So fast access, low barrier access to treatment, especially in the acute care setting, but certainly from the clinic setting as well. You shouldn't have to go find an addiction specialist to be able to get started on these medications. A personalized evaluation and treatment plan that looks at the actual barriers for that specific patient, the needs for that patient. Maybe it's peer support, maybe it's transportation, maybe they need to do telehealth because the closest clinic is 2 hours from you, but being able to understand what your patient's needs are. Long-term treatment and follow-up being something that's also easy to access, in part because whoever starts you on medication has that clean line where they can hand you off in a warm way to the next person, instead of just saying, here's your packet of resources, good luck to you, we'll see you next week, which has not been working for decades. Coordinating care for both mental and physical health. It's important, right? Yes, getting them on track with the buprenorphine piece is one part, and then, as Dr. J so astutely mentioned, we got to look at all the other parts that contribute to substance use disorder. Looking at access to medications for opioid or alcohol use disorder. This is one of the tenets we share. We're not going to talk about it today, but we're in support of this too. There are some good medications out there and evolving research about how to do that in alcohol use disorder as well. Having additional services to support recovery, like a peer navigator. You can call it lots of things. There's a conversation in the chat about that. Doesn't really matter the name that you use. We landed on Substance Use Navigator, but having somebody who's available, not just mandating, NA or AA or specific group therapy. It needs to be unique to that patient, and looking at outcomes, making sure that you're actually keeping people in treatment the way that you mean to. And if you're not, figuring out what the barriers are, which we're happy to talk more about. So I'm actually going to stop sharing my screen for this moment, and we'll open it up if anybody has questions. You can feel free to type them in the chat, or feel free to just unmute yourself or raise your hand. The raise your hand feature is really helpful, and we'll look out for that. I do, just in case somebody hasn't been following the chat, want to address a few very brief things. One is, can you start buprenorphine when a patient has shown up after a rescue from overdose? They overdosed, they got naloxone, Narcan, they're rescued. And the answer is yes, you can. And we put a link to a nice little protocol that walks through those steps in the chat if you want to check that out. Same thing for pregnancy. Yes, buprenorphine is safe in pregnancy. And so we have a nice little protocol we stuck in there for that, if you're curious about that. And then there was a robust conversation about Substance Use Navigator. So if it's okay, I'd like us to start there. A few of the specific details were about what did the credentials of that person need to be. And I had mentioned in the chat that we believe it doesn't have to be a licensed social worker, a certified drug and substance counselor, because we have noticed in our work that people in recovery, peers, are the best substance use navigators. And then that brought up the question of reimbursement. So I don't know, Ariane, if I can put you on the spot, if you want to comment about that.
Yeah, this is my jam. So I'm a big believer in navigators. We developed this with the idea of keeping the patient at the center of care. And we knew that having navigators would make a big difference. So when we developed the Substance Use Navigator program in California, and if I can just put a shout out, we got funding for a substance use navigator in every single emergency department in California. So this passed through the California state legislature. This is funded from California, and we are creating universal access. So all 330 hospitals will get a navigator. That being said, we looked at many different navigator programs out there, and what we wanted and what we knew we needed from working in emergency departments for this long is somebody who truly cares for a patient and can help advocate for them and change stigma, language. There's a lot of barriers in emergency departments that they're working through. Indeed, for reimbursement purposes, I agree that you do need certification. So that's why we worked with the CDAC to help develop sort of some navigator, like the peer support specialist, because realizing that indeed you need certification for billing. And what we're really hoping, so in the outpatient space, they can bill, not yet in the emergency department and inpatient space. So we're trying to get through some of those things in order to get to a place that hopefully, if funding rolls out where there's reimbursement available for the ED and inpatient setting, and we're very much hoping for that there'll be a certification that our navigators will have. We don't require anyone. We just we have some that we send resources and have that available in our Sun toolkit. And Sarah, maybe I'm hoping if you haven't already, you can put in the chat our Sun toolkit, and you can get a little more of the details on how we train our navigators, what we find very important, for example, motivational interviewing, de-escalation training. There's language, there just some information about the medications themselves, but they're really there to be our change makers and to be a friendly face for our patients. So hopefully that addresses all those questions, but that is the premise, is trying to create this change. And then we're also building that workforce for hopefully in the future for reimbursement purposes.
Yeah, I would also add that this is very Pollyanna, what I'm about to say. So I'll acknowledge it, that in healthcare, sometimes dollars and cents are not Pollyanna. However, in an ideal world, right, like not every single provider in our hospital direct bills and reimburses for their time. So social workers can do an expert, but a lot of the work they do doesn't get individually billed by encounter. Same with case managers. And yet hospitals see intense amount of value in that because they watch recidivism rates go down, they watch follow-up rates go up, things that are good for care over time. So we do have some of our sites. UC Davis specifically has done a good job of looking at the bounce back rates and the continuity of care and what estimated cost savings that led to their system that more than made up for the cost of a navigator. So we're trying to tackle it from multiple approaches, including reimbursement, because we do think probably at the end of the day, our best argument's not purely going to be reimbursement based. It's going to be proving value in the actual continuity of care and decrease of the ER visits for some of these patients.
Yeah, we actually did publish in the DAD journal about, and I think it's JSAT, something about some of the navigators. So we do have an implementation paper that was published in Annals of Emergency Medicine that also talks about the model, the implementation model. And maybe we can put that in the chat, the Annals of Emergency Medicine article there we go. Perfect. All right, there was one question about methadone that I'd love to answer.
I was just going to say, yeah, the next question that came up had to do with, and I'll just kind of paraphrase, why are we focusing on bup, not methadone? And then it's mentioned in the 72-hour rule, kind of saying like, hey, methadone might be a viable option. Why are we not doing that?
So buprenorphine for the purposes of the emergency department is pretty simple, very quick acting. We like things like that in emergency medicine, meaning it's a sublingual medication. Many of our patients are vomiting, stabilizes them very quickly. So within 15 to 30 minutes. And it's also, we have various sites. So California is a very large state. So what we have found is, like, for example, I live and work in a rural community with no methadone clinic until a satellite clinic just opened up about maybe 2 years ago. And the satellite clinic, you still have to travel at least 2 hours and 15 minutes once a week to go to the main methadone clinic. So though it's patient-centered care, if somebody says methadone is what works for me, I will, we have a start guide actually, and we will also start folks on methadone inpatient, but we more typically in the emergency department setting go with buprenorphine because of its properties of safety, its ease of use, our ability to prescribe it prescribe methadone. So it gives patients a chance to find that follow-up piece. But certainly it's patient-centered care, and there are a lot of facilities that do start methadone. I know at UCSF in San Francisco, they start methadone in the emergency department because they have such great access to methadone in that community. So it just depends on the community. It depends on the location. But in general, we're advocating for buprenorphine starts just because it's what is typically the easiest, best approach for us in an emergency department setting.
Yeah, I do think there are other physiologic reasons why we like buprenorphine. It tends to have a lower overdose risk and those kinds of things too. But we very much are big on medication for addiction treatment means put your patient on medication. And if methadone is the right medication for your patient, that's fine. If buprenorphine is the right medication for your patient, that's fine. From a regulatory and access perspective, we have found buprenorphine to be much easier. There's, they can go home on a prescription with a provider with an X waiver, which now they've eliminated the training for that, which is great. I still think, to be clear, that everyone who's going to have an X waiver needs to learn about it before they do it, but they certainly don't need 8 to 24 hours of training because we didn't get 8 to 24 hours of training about heroin use, right? So or how to write Norco prescriptions. I don't think I need 8 to 24 hours of training on how to give the treatment for substance disorders either, but there are going to be patients where methadone is the right medication. So we're not advocating against it. We're more talking about the ease of use of buprenorphine as a rapid start medication, which does tend to serve our needs a lot in the acute care setting and is an easier, low barrier, ongoing thing for patients as well.
There's a pretty fun question that also that I got excited about is, what if a patient's not ready for buprenorphine or says, nah, I'm not, I'm just, things are going fine. We all have patients like this all the time, of course. So I know we have harm reduction in my emergency department. We literally have take home Naloxone. I hand boxes of Naloxone to patients. I have safe syringe kits. I have smokers. I have fentanyl test strips. I'm trying to actually get a machine so that folks could test their drugs to see what's in them. So we're taking a whole harm reduction approach because we're finding great engagement with patients. So it doesn't just stop at buprenorphine. We're really trying to provide this center of care for folks. Lonnie, have you had some patients who are a little ambivalent, or I know that there's been a couple of cases in particular where you were able to engage patients?
Yeah. So what I actually did want to say in terms of, so I did not work at an opioid treatment program. I work at outpatient clinic. Buprenorphine and naltrexone are what we offer. And I think the thought for a while has been that less stable patients that are really struggling, that are experiencing homelessness, that have multiple substances on board, they need the support of a methadone program, an OTP, they need daily dosing, they need all of that. And yet, in my experience, that hasn't been an option for patients. And so we have been at ground zero trying to figure out what we can do for these patients where methadone is not an option. And we have seen them stabilize very well with buprenorphine. And I actually am a huge fan of Sublocade. So the monthly long-acting injectable buprenorphine, I have seen people do really, really well on that. And I've seen in the field that people have reserved that just for people that are well stabilized, that deserve a month of treatment in between coming back in. And actually, I advocate low threshold, long acting injectable. I think getting people a month where they're not going to overdose on you on board as soon as possible is one of the best ways to stabilize very high risk patients. And so that has been one of my favorite and very successful way of seeing very challenging, unstable patients do really, really well on buprenorphine. My hope is that the future of buprenorphine management is that we can give long acting injectables from the ER because why would we not give people the best tool possible to prevent overdose in that moment? And I know that can come across as a different train of thought from people that have had a lot of experience in methadone. And I think these are both very important pathways. In our rural county, we're doing the best we can. And now I'm working in 2 rural counties. We're doing the best we can where barriers keep people from coming in for frequent methadone dosing. And a lot of the county, I mean, we've been missing a lot of our rural county. And so I think this is a very important option to get out there.
Yeah, one thing I want to mention, because there's a lot of comments in the chat about like regulations and rules, and they are very much dynamically changing. You know, even just how we access the X waiver is changing. It used to require, so I want to make sure I clarify this. It was asked in there. It used to require an 8-hour training for a physician and a 24-hour training for a PA. Like Ariana had to do 24 hours of training, which is absurd. But now you don't have to do that training piece. So providers to prescribe buprenorphine as an outpatient prescription, you do still have to have the X waiver, but it's just an online form that you fill out now, as opposed to having a precursor training requirement. And yes, there's a ton of advocacy, thank goodness, being done out there about making it more accessible, getting rid of the X waiver. I know the American College of Emergency Physicians, for example, is very much front running the fight against getting rid of the X waiver. There's a mention in here about how mobile methadone clinics are allowed now. Yeah, they are. There's tons of great changes and a lot of hardcore advocacy being done to improve lots of things. Reimbursements for Sublocade, or not for opioids, but naltrexone, right, for the injectable for alcohol use disorder. Lots of other medications that currently are not easy for us to give patients because of payment reasons. There's a lot of work being done by different agencies and groups to fix that. So we acknowledge that, we're excited about that. For right now, I think the advice we're offering is more about how to work within the system that we currently have, and hoping that we'll be able to update all of our information in the very near future as things get easier for our patients and not harder.
And I want to reference back to our presentation. We really are trying to tip the scales to make buprenorphine more available than street drugs. Like that's with that ceiling effect on respiratory depression, I consider this airway management. Like I try to load buprenorphine after a non-fatal overdose to protect a patient. We really do for our pretty straightforward overdoses. Our standard in our emergency department is to offer buprenorphine, to offer referral, to hand them naloxone in hand. We've developed a whole protocol that we're implementing right now where this is our standard. We offer referral, we have them see our substance use navigator, we have our substance use navigator follow up with them. I mean, overdoses are continuing to increase. So we have to have this like all hands on deck approach. And we're really trying to make sure we have access to buprenorphine very easy, because historically there's been so many barriers. So that's part of our model, really. I've had a couple of patients come into my emergency department requesting buprenorphine who maintained their own programs on the street for 2 years. They were on 16 milligrams for 2 years because we did not have a friendly enough environment for them to feel comfortable coming forward and noting that they had a use disorder, until they actually word on the street was that we were treating, that we changed how we treated people who use drugs, and they felt comfortable coming in finally. And those were big wins. And actually those 2 patients are on Sublocade now, so on the long-acting injectable. So there's also this whole system, has been pretty crazy, right? From a patient's perspective, you have to be on time. You have to make this appointment at a certain time. Maybe you're working, and if you leave work, you'll lose your job. All of the things that help create stability in your life, there's been barriers to patients actually getting this care that we've recognized, especially having that 24/7 access for folks. I think, we know we're seeing some of our most vulnerable patients who aren't going to be able to, at that moment in their life, make an appointment 2 weeks down the road, a month down the road, and keep it. So we're really able to start a lot of our most vulnerable patients on treatment. And we've had, my follow-up rate at one point was 97%, meaning our patients who are coming in, they want treatment, and like nobody's faking an opioid use disorder to get bupe, right? Mm-hmm. They are coming in and getting treatment, and they are following up. More than half the patients I've ever started from the emergency department setting are still in care. So, these are huge wins, and we just get that moment to capture it in the emergency department. That's helpful, and connect.
There are 2 things I was thinking, Lonnie, maybe you could address just from your outpatient perspective. So one of them is this idea that was mentioned about if a patient's not ready for care. I think in the ER, we have this moment where they're in like a crisis mode, vulnerable. It's a little easier for us to sell it. But there's a really thoughtful comment in here that's like, hey, in my clinic, it's available, but nobody wants to do it. So I would love to hear your thoughts on that. Yeah. Then the other question that's directly asked, which was, how do you prevent abuse? I would just be interested to hear you answer those 2 questions.
Yeah. So as far as the question of what if people aren't ready, so a lot of people present in withdrawal, and what's amazing about buprenorphine is 30 minutes later you're going to prove to them that actually there's a way they can live their life without withdrawal. And so many people continue to use opioids because they're running from withdrawal. Often the high, the euphoria, that gets tampered down by your brain. So a lot of people say they're not even chasing high, they're just running from withdrawal. And so a lot of people continue to use because they don't know there's another option. And yet proving to them by giving them the medication in the ER, suddenly we've all heard this. We hear this time and again, oh my goodness, I have my life back. There's a way I cannot do this. And so that's part of that question of, are people ready? Part of it is they don't know what they don't know. They're left alone on their own to stabilize. And so making medication readily available, getting them out of withdrawal, letting them know you can have this medication, you can have all that you need to stay out of withdrawal and stabilize, that's a big part of it. If you're offering people buprenorphine, but they are continuing to use and not coming in for appointments and don't want to engage, making sure that it is a safe place where they can always come back at any point, employing motivational interviewing, having counselors call and check in and just let them know, hey, we're here, offering them clean syringes and harm reduction services so that when they are ready to engage, anywhere on the spectrum where they're at, from active use to stability, wherever they're at, that your clinic is a safe place for them. That is one way to be a safety net for people that aren't ready to stabilize. And then at every visit, using the motivational interviewing and counseling techniques we've learned to help explore motivation and help them move their motivation along. That is the best we can do. I've also had a family medicine patient with an A1C of 16 for a very long time. And so we do the best we can for people that are not ready or able or willing to stabilize their disease. But at the same time, I'm going to look to see what other factors in their life might be contributing. I'm going to address their sleep. I'm going to address their mental health. I'm going to make sure that they stay with that they continue to have insurance so that those things aren't barriers for them to come in. So we view it within the spectrum of family medicine and primary care like we would with anyone else that is struggling with an active disease process. Does that answer your question? I know that's hard, but even off and on buprenorphine is safer than no buprenorphine. And if you can catch people in a moment of motivation and get Sublocade on board, long-acting injectable buprenorphine, that's a great win. And so the question of how do we overcome barriers for long-acting injectables, with cost, we're at a point of needing advocacy to make this easily, readily available. If someone's ever tried buprenorphine in their life and they don't have an anaphylactic reaction, then at any point it's safe to give them a Sublocade injection. And so there are patients where I've ordered it, they weren't interested, I kept it in clinic, but they came back at a later date and I had their Sublocade that I could give them. And I've done buprenorphine starts with Sublocade, which is an off-label use, but I think it's the future when people are at a moment of motivation to get that stability on board. And what was the second question?
It was about how do you prevent abuse, especially for you as an outpatient provider, as you're continuing to write these prescriptions.
Yeah, so abuse is something that we have to watch out for because we have medical licenses to protect. Most of buprenorphine is used for its intended purpose, which is to stabilize withdrawal. At the same time, if there's somebody who I am monitoring their urine to make sure they're taking what I'm prescribing and it is not coming up positive for buprenorphine, it's an opportunity to have real conversations, meet them where they're at and try to see what we can do to stabilize. If I hear of someone actively selling their medications, I might do witness dosing, which is something we do just to make sure they're actually taking buprenorphine because we have to cover our license. But at the same time, making buprenorphine freely available to anybody in the community who wants it is the way that we decrease diversion, is that anybody can get it. And so that is our perspective. As far as abuse, they're injecting buprenorphine instead of taking it sublingually. You know, off the record, I'd still rather they inject buprenorphine than inject fentanyl because they're less likely to die. However, that's why we prescribe the preferred versions, which are buprenorphine with naloxone, to make that safe. And so I'm doing the best I can, just like all the rest of us are, where we also have licenses to cover. If I know somebody is selling or abusing their diverting their buprenorphine in a way that I'm not comfortable with, then offering the long-actable injectable buprenorphine is a great option, because you can't abuse that. Well, you can't divert that.
Mm.
Can I just ask you a question?
Yeah.
I'm from Indianapolis. We have 5 major systems in Indianapolis. None of them does anything like what you guys are talking about. And I either need someone to come to Indianapolis to help us with this, because numerous people are just coming in on a regular basis, and we see 133 overdoses every week.
Yep.
And basically buprenorphine is not being administered.
Yeah.
And so
So we're here to break the mold. We are here to do something different. California is leading the nation in doing something different.
I understand that, but the point is getting physicians in the ED to spend the time on this is very difficult. And it's almost been, I keep saying to myself, why are all these females in the ED doing this and males are not? Because then
it's a paradigm change.
We just have deaths, considerable deaths.
I did just look at at some numbers, and there was one medical center that I'm aware is treating with buprenorphine, and they literally last quarter treated with 10 times the amount they had the quarter before. So there is a program, and I don't know if it's in Indianapolis, but happy to talk to you and happy to help you get started in Indiana, so it's more widespread and universal, because it is troubling when there's no access. But what I can tell you is we've been able to, so once you give the right information, and Alicia and I, Lonnie, we're all doing this all the time. I know we spoke, we have presentations all the time. We're really trying to get this out there rapidly. Once we give the right information to our emergency department crews, we've had really rapid uptake. So I just want to let you know that I did just look at a graph this morning where somebody in Indiana is starting to give the medication. Please contact us. We love to get programs started and to help implement. That's our jam. That's what we published in Annals, is our rapid implementation of programs across California. And Sarah Wendells is also on this call. We are, or on this presentation, we are very rapidly expanding across the country. We have been assisting, now we're up to 25 different states that we're helping implement this same type of model. So whether the Medicaid expansion, non-Medicaid expansion states, we're jumping through lots of hoops to just get treatment to the folks in your community. So that's why we're here.
I tossed our contact info up. Please feel free to snag our emails and reach out. We do 100% help provide you with a person, one of us or somebody else, but to do an actual presentation for your ER. We've done site visits before. We've done lots of things to help individual hospitals. And what we found is that typically geographically, it takes a couple of leading facilities and then everyone else slowly starts to fall in line. So if you want that to be, your hospital, let us know. And we'd love to help you do that. I'm actually leaving as soon as we get off this call. I'm going to get on a plane to go to Kentucky to do this exact same thing in Kentucky. You're not, Indiana's not the only place not doing this. In California 5 years ago, we weren't doing this either. It's definitely, unfortunately, new medicine, but it's great. And so we're here for you. We're happy to help anybody who wants to get started.
And I will say my husband's from Indiana. He's a Colts fan. We come visit family. So if you ever want me to come and talk to people, I'm happy to. I think from the provider perspective, most of the time our reticence to make change is just, we don't know, and we don't know what we don't know, and we feel uncomfortable. And so that's why I work in a residency right now, where I can be part of the paradigm change, training new providers to do this differently, because it's a very fast change that's happening in our country. Our understanding, our approach to how do we stop people from dying from opioid overdose is very fast. I was in residency. My intern year was just 8 years ago. And I remember hearing that no one's ever died of an opioid overdose. And I now know that's not true. People die from that scenario all the time. And so it's a very fast change in our understanding. We are working on changing it in medical school and residency. And those of us out in practice, we have to pick up practice change all the time. And, that is why these two providers that work in the ER, Ariana and Alicia, that is their message, is we can help change practice for providers that are seeing this in the ER. And in primary care, we are scrambling to then be the much needed outpatient piece. So thank you for being here today to be part of the solution. And we're also happy to continue to help.
Not to shift gears, but there's a medication related question that was asked about buprenorphine. They said that at their experience, they've really been leaning towards using more methadone because they feel like patients keep getting precipitated withdrawal when they try to use buprenorphine. Ariana, I know this is a thing that you love talking about. So you want to take the first stab at this one? Yeah,
we've developed a protocol, and actually there's a new single big dose paper that was published in JAMA by Dr. Andrew Herring, which is one of our founders as well, and one of our co-principal investigators. So there is some room, of course, for the microdosing in the age of fentanyl. It's all fentanyl in my community right now, so we're seeing a lot of fentanyl. But what I'm actually seeing is also then an underdosing, which looks like precipitated withdrawal, because folks are just in withdrawal because they're not getting enough buprenorphine. So that's when it looks a little trickier than it should be. So I have given very small doses of buprenorphine to folks when they're really afraid of withdrawal, just to load a little bit. But as soon as they're in full-blown withdrawal, and I look for physical signs for that, like sweaty forehead, dilated pupils, tachycardia, with those things, then I will actually give them a much higher than usual dose. I will admit, I had a patient who was intentionally smoking fentanyl, a lot of it, and I ended up giving a lot of buprenorphine. This particular person, it did look like a precipitated withdrawal, but in order to sort of overcome that void, I ended up giving, in my ED, I gave 40 milligrams of buprenorphine to overcome that. And she walked out of the emergency department feeling normal and comfortable. So we've just had to sort of keep the patient at the center of it. We are actively developing a protocol for fentanyl in particular, but which will take into account some of those microdosing. But I'm a bigger fan of making sure if they are in full withdrawal, that we are treating their withdrawal aggressively with buprenorphine, and found that patients get better very quickly. We've also had this very slow starts for patients. And I do consider, just so you know, 4 milligrams, I call it the confusing dose, because, I'm watching my patients and it's either not enough to fully treat their withdrawal or just enough to precipitate with their withdrawal. And so I find it very confusing because I don't know, I just know that they're still in withdrawal. So I frequently start at 8 to 16 for patients who, in fact, 16 more often now that patients are using fentanyl. But I frequently start at higher doses actually in the emergency department setting and have been successful at that. But I do recommend, and maybe we can put it in the chat, is that single big dose article from Dr. Herring that he recently published in JAMA.
Yes, Sarah
talks about
popped the article in there, and then we also have a link to our 90-minute bundle for withdrawal.
And there is, and the other thing I have to say about precipitated withdrawal is there's a window. So I watch the folks when I address their precipitated withdrawal very, very quickly. And our bundle is we give 16 milligrams of buprenorphine and 2 milligrams of Ativan. So I've had some folks decline the lorazepam. So when we do that really quickly, we're able to overcome that as well. And so we've shifted to that, because we've noticed this sort of long drawn withdrawal process. And you know what we want? We want patients to have a good experience. We want them to understand that this is a life-saving medication that's going to help them. We don't want them to have a bad experience or continue in withdrawal. So anyway, so just to address that, I love to talk about this even more. So please reach out and we can chat.
Yeah, and then there's a question that's a good one about, we did not talk about this here. We did talk about it in the longer webinar series, but the difference between buprenorphine versus a bup naloxone combination. And so in our acute care settings, or like in your clinic, most people will administer buprenorphine plain because it's cheap. It's really, really cheap. And it works the same. The difference is for the outpatient prescribing. You're writing somebody to take one home. We like the combination. Most commonly, we'll use Suboxone, the buprenorphine naloxone sublingual tablets, or the buccal films. And the reason is just that it helps prevent abuse and diversion, because if you were to try to abuse it, snort it, inject it, the naloxone does kick in, which prevents you from being able to get a high. Whereas if you're taking it correctly, sublingually or buccally in the cheek, the naloxone is inert and doesn't do anything at all. And so that's one way that we kind of help. We should have, I think, probably mentioned that earlier. We all forgot, but that's one way that you can help with that. But in your actual, like, you know, witnessed setting, you can give plain old bupe. It's like pennies on the dollar compared to the cost of the brand name. And then for the precipitated withdrawal, I just wanted to mention about the benzos using a 2 milligram lorazepam. If you're in a community where you're starting to see a lot of fentanyl, I think most of us would agree that when you know you're dealing with a patient who uses fentanyl, we almost always give 2 milligrams of Ativan, lorazepam early on, and we've seen a lot of success with it. I'll be frank with you, that's kind of anecdotal, but it's like hundreds of patients anecdotal from our California Bridge program team and all of our substance use navigators, that fentanyl, for whatever reason, during a buprenorphine start tends to cause a lot of complications, agitation. It might take higher dosing, so it takes a longer time to get there. And giving that early on dose of a benzodiazepine can make the experience a lot less painful and agitating for the patient. So we've had a lot of success doing that.
Yeah, and to comment on that, just we actually have a Center of Excellence project now. Sorry if I have dogs barking, but I have a Center of Excellence project. So we get together with some sites that are giving a lot of buprenorphine, and we talk about these issues. And some of the stuff we're developing is based on our Centers of Excellence because it's such high doses of, high amount of buprenorphine starts. So
there's also a great question in here about if you're in a community where there isn't a lot of bridge programs, or there isn't an ability to connect to MAT, what are systems doing, or what are you recommending about how to create those opportunities? How are we getting people to say this is important, that we should have a bridge clinic, we should have an MAT clinic? Lonnie, I would love to hear any thoughts you have about that.
Yeah, so it is a challenge when the outpatient piece is not in place. So what ER providers that are starting this bridge work are finding that they have an inpatient problem with an outpatient solution. We in the outpatient world need to be there for this process to work. And even with the challenge of getting ER providers to change their practice and start buprenorphine on board, that's an easy piece. But the outpatient support needs to be there, and that's going to take some time to build the services. In our community in Amador County, we are working with the county. We are working with the FQHC to do education. There is some telemedicine option, which has actually been a very successful part in our rural county. And so telemedicine, if there is absolutely nothing, that's a great place to start. The other thing is going to meet with the county to see what they are providing, and then working with the FQHCs or the residency programs in the area. Because I think from all the different trainings, all the different sides, the word of this is getting out there. So there are probably small places where people are getting engaged, and it's bringing everyone together to build this, which is just that last needed piece. And that's what we've seen in El Dorado County, where Ariana and I have done some work that it was fragmented until it came together. And I think a lot of places are on that cusp.
Yeah,
and until then, telemedicine's an option. So even just in my regular primary care practice, I can see people for a video visit if they're needed. Yeah,
I was just gonna say the thing about telehealth. You took the words right out of my mouth.
Yeah.
But another way to, like, with the systems, you know, people feel like it's not they talk a lot about reimbursement, right? That this is not lucrative. You can't bill very well for seeing a lot of patients that do MAT. And there are, a lot of clinics out there that don't accept Medicaid. In California, we have our own title for everything. I apologize. Yeah, Medicaid. They don't accept Medicaid at their clinic, which makes it pretty hard to get a lot of these patients into outpatient care. So this is one of the reasons that we advocate, not everybody has to be at an actual MAT clinic. A lot of patients, once they're stabilized, can just continue their buprenorphine with their primary care provider. And it's all a matter of just educating up. I say it's like it's easy. I acknowledge that educating physicians and changing practice patterns is actually very difficult, but it would be as simple as educating your outpatient teams regarding how to continue someone on buprenorphine and making sure they all have their X waiver. Maybe that patient then only needs a once a year follow-up with a MAT clinic or a bridge clinic because they're just really doing well with their own primary doctor. So sometimes it's not, let's build a brand new clinic. It's gosh, let's use these telehealth resources or this one place that does exist, but get our regular outpatient providers to a place where they can continue that care once the patient reaches a stable dose.
Yeah, and what I was going to comment on that a little bit too. I think that's what we're trying to build in our community, because we all know, we've looked at the numbers. We need capacity, right? So it just makes sense. Like we have bridge clinics. In fact, in my rural community, we started with one X-waivered family practice physician. Again, we have no addiction psychiatrist. And now we have 4 options of 4 different clinics from the emergency department because we built this and we're building the culture. Now we're trying to build the culture so family practice physicians who are not necessarily, prescribing a lot of buprenorphine are just able to receive their stable patients back and continue it. So really the same model as with every other medical problem. If somebody has uncontrolled hypertension and you can't figure it out in the family practice clinic, they might see a cardiologist, they might have some other consultations, and then once they're stabilized, they land back with a family practice physician. This is how we can build immediate capacity, right? So that's one thing that we're certainly advocating for. The other thing I wanted to acknowledge, Alicia, in terms of the question on bup naloxone, that I do have some patients who tell me they get really sick when with the combination product, and I listen to them because I want them to be on buprenorphine and not feel sick and not go return to use of fentanyl or heroin and overdose. So I listen to them, and I know in the outpatient setting, Dr. J has started folks on on the long-acting injectable when there's this question of diversion. So I do think there's plenty of options for folks, and I just have to put a plug in. I have a lot of patients who have told me that the naloxone component has given them some adverse effects, and so again, I still want them on buprenorphine. So
yeah, another thing I tossed in the chat just in case you want to jot it down. No matter what state you live in, there's a national clinician consult line for substance use, and they answer the phone between 6 a.m. and 5 p.m. Pacific time. So I'm not going to pretend to successfully do time zone math, but I did it right. So you can call them, and they can also leave a voicemail 24/7 and they'll get back to you. But it's an expert. And so they're really good at, like, it could just be you're calling since it's your very first time starting buprenorphine and you're not 100% comfortable, and you've got the California Bridge protocol, and you're like, I think this is what I'm going to do. I just want to make sure I'm not missing something. They're good at that. They're good at, hey, I just think I precipitated withdrawal in this patient. What's going on? Can you help me? They're good at, hey, I'm in the clinic and I have a patient who's on bup and I'd like to continue it, but I don't feel comfortable. It's a really wonderful resource for any of those avenues. And sometimes it helps you feel like you have a proverbial handhold getting through the first few. And what I have noticed, what we've all noticed in working with now, gosh, how many hospitals, 100 and something hospitals, we have noticed that it really just takes doing it a couple times. Like the first time it's very stressful, second time, third time, fourth time, you're like, oh, this is actually a very, very easy medical thing to do. But it helps to have that backup, that warm line available to your doctors and your PAs and your NPs and your whoever.
And one more thing I did want to say, we have we've had in the California Bridge program, very few precipitated withdrawals. So I know we talk about it a lot. Now, I do have to say we intentionally precipitate withdrawal all the time when folks are overdosed. So this is something that's in our wheelhouse for sure, but very infrequently do we see any bad precipitated withdrawals. And I think in the first 2 or 3 years of our program, we saw only at like 1 or 2 that of folks that we started on buprenorphine. There were some, folks who tried buprenorphine on the street, had just used. We saw some folks like that. We're seeing a little bit more uptick in that with fentanyl, just I think like the rest of the country is. And so we're stepping, that's why we developed a protocol for precipitated withdrawal. But I just wanted to comment that we do see it's not a usual thing. We still see a lot of very straightforward starts. And to your point, Alicia, like I think there's been a lot of that, like that first start feels really big. There's language, like it's an X waiver that I initially got, and this is an induction, and that all felt scary. And so I really did stare at my patient for an hour when I gave her buprenorphine the first time. I was just like, oh my gosh, what's going to happen? and she was fine, but she was like pregnant, she was 24 weeks pregnant, and she was my first patient. So all of those questions, like she just did fine. She was in withdrawal and miserable, and she got better. So by and large, our patients get better. One thing I did want to ask, like this comes up a lot, urine drug screens in the emergency department. We typically don't get them. And Alicia, I've heard you talk about this before. It's not our routine to get any labs or urine drug screen in the emergency department to start a patient. But I'd love to hear, Alicia, if you can comment on that.
Yeah, this one does come up a ton. I've actually worked with many hospital systems where they feel that you have to prove it. What we have found, and what I think makes sense, is patients don't tend to lie about what they are using. Like typically I feel that people are using urine screen to screen for like, well, your alter, you said no drugs, but did you really use drugs? The patient comes in and says, I use heroin and I'm in withdrawal. They are. And there are studies to prove that they're right. And not only that they're right, the patient without any objective scale can nail it and how bad their withdrawal, how bad their dope sickness is right now. They're really, really good at that. And so we trust them. And I think a really big piece of this is also building trust with our patients in an environment that has not historically been excellent at this. We have built a lot of stigma. We call people, junkies, addicts. We use phrases like, let's get that guy out of here. Let's kick that girl out of here. I'm going to get them out. I mean, these are like not very warm and welcoming, but instead stigma laden terms. And so to truly approach someone and take them at their word, like, yeah, I believe that you're using that drug and you look like you're in withdrawal, and let's fix that for you. I want to help you. And having that medication first, make you feel better first, treat the pain first type of approach is transformative in what that culture looks like, and that patient's ability to trust us in the healthcare system, rebuilding those bridges. So we are huge advocates that urine toxicology screening can be useful in the ongoing outpatient care arena when you're just trying to look for compliance. And like Dr. J said, then facilitate a conversation. It's not so you can fire that patient and say, you didn't take your bup, you're out. You wouldn't do that to somebody whose A1C is 10, you say, you didn't take your insulin, you're out of my clinic. You wouldn't do that. But having the A1C is a helpful piece of the conversation. Having that urine toxicology is a helpful piece of the conversation. In the ER, I don't need an A1C, and I don't need a urine toxicology screen. I just listen to my patients and I look at how we're doing right now. So it's both a culture shifter as well as not wanting to waste. Oh, plus anybody work in the ER, like, do you know how hard it is to get people to pee in a cup? It takes forever. I don't know why. It takes an inordinate amount of time. And so why would you add a test you don't need that is the most difficult to collect of all the tests that you could possibly collect? So it's a huge burden on the system to do that. It's really not necessary.
It's liquid gold.
Yeah, I am leaving up
produce.
this QR code here just briefly in case you want to take a glance. We've been posting a ton of resources in the chat, but if you were just like, I'm not going to write down every single link, no worries. Start right here at californiabridge.org. And you can go to our actual resource page. You can see what it looks like here. It has these nice little tiles. You can search it for any of the things we're talking about and so much more. I just wanted to make sure that we give that a beat here. And then if you want, I'm doing this now because we'll stay 10 more minutes, but in case people have to jump off, I know that people have competing meetings. Again, come to our website. It's super helpful. You can also come and join our mailing list to hear about trainings. Our trainings are free to anybody, everywhere, all the time. You're welcome to come and listen to us. You can also see a repository of the things we've done before on our YouTube channel. So come to our website, take a peek at it, and then I'll land here again, just with our contact info in case you want to jot it down before you go. Adolescent patients and self-reporting. So that's a great question. Somebody said regarding the urine toxicology screenings, I have found that if you talk to an adolescent like an adult in the absence of their parents, they're very forthcoming and they're very truthful, especially when I reassure them that there are laws that protect me from keeping some of this private and that I want to help them. And if they don't tell me the honest truth, it's going to end up causing complications. And that's not what I want. That I'm asking because it helps me know what's in their body to pick the right medicine. I've had a lot of success with that. Ariana or Lonnie,
Yeah.
Comments.
We have a youth resource too. So we are doing work with youth, with adolescents, and we have one of our projects involves youth. And it certainly depends on, I just noted, it depends on the context. So having a private discussion with an adolescent is usually very, very helpful because, you know, and it is that awkwardness, of course, in the emergency department, we do have parents bring down their kid because they suspect drug use and they want a drug screen immediately. And you know, these are always tricky discussions because we're trying to advocate for best patient care and diffuse situations. And so can I say this is always easy? No, but one thing I'd like to comment on that one of my partners, Amy Moulon, has really pointed out is that, you know, we always talk about prevention for youth. Average age of first use is 12. By definition, addiction is a pediatric disease. We need to start talking about treatment, right? So that's one of our projects where we're really talking about treatment, not just prevention in adolescence, it's treatment. So we have some great tools for adolescents. And I think, yeah, Sarah, thank you for putting that in the chat. We have so many resources. I just have to comment on this. We care about this work clearly greatly. And so when things come up, we have been very busy developing these resources to answer all of these questions because these questions come up so frequently. And we really want to provide folks with great information. But yeah, the youth question is coming up more and more. And but that's where we're at is certainly advocating for treatment as well. So yeah, it is.
The other thing about urine tox screens in the acute care setting is that remember that test most of the time, the one you have in the ER was developed for the police. It was not developed for healthcare, and its sensitivity and specificity of that test is trash. Like there are certain medicines like methamphetamines, you have 50-50 chance over whether or not that result is correct, whether it says positive or negative. You could take a Benadryl or a Reglan, a nausea vomiting medicine, and turn that thing positive. You could inject methamphetamines in your system and it can pop up negative. So urine tox screens have significant limitations in our clinical setting. And so moving towards talking with your patients and being stigma free about their answers and explaining why you're asking those questions is far more successful than relying on a really, really inaccurate test. Again, that comes from like the most difficult to obtain form of all the tests.
Yeah, the two of the things that I get most concerned about with patients would be like Xanax, alprazolam and fentanyl. Both don't show up on our drug screens. So, and the drug screens come back in 3 days if we do send them out. So though we utilize them for overdoses for certain toxicology reasons, we all know that they are inaccurate. The only accurate part of my drug screen in my ED is cocaine. And if that's only if they've used in like the last 24 hours. So it's really can be, it can sort of distract from your care. Though there's certain times, with certain things where we do need to get it, we don't use this by and large just to start folks on buprenorphine. So we just talk to them.
And Rachel made a comment about this that bears worth stating, which is there is another very effective and helpful use of urine toxicology screening is population health-based monitoring what's in your community. So yes, there is some utility to knowing like, oh gosh, look, fentanyl started popping up all over the place on our toxicology screens. Wow, like they really hit our community. That's very helpful, but it's still not going to be relevant to us acutely with the patient sitting in front of us. But there are roles for that testing. It's just not, it shouldn't be a barrier to starting or continuing a medicine like buprenorphine.
One of my partners down in Monterey, actually, Reb Close, she got a mass spectrometer in her emergency department, so folks can test what drugs, like what's in their drug, like you can test percentages, how much fentanyl, like so there's informed choices that folks can make, so they know what's in there. And that's ultimate harm reduction, right? And having that available 24/7 is really important. So I think it's a mobile unit too. So anyway, we're getting better and better at this. We're trying to get better at the harm reduction approach too. And you know, a lot of my folks who use they're very good at like trying to test for things. They are really trying to take a harm reduction approach in terms of they don't want to overdose. So, and if we provide that compassionate, respectful care, then I have found more often than not that we're able to make a difference. I've even had some folks who they may not have stopped using methamphetamine, but after some conversations, they changed from injecting to smoking. They reduced their use. In turn, they were able to get a job. And really, you know, some of those really easy conversations from us can make a huge impact on patients. So, and providing harm reduction resources can open a conversation. So.
And just to add a little to the nuance, this conversation about not needing it in the ER is maybe different from the outpatient world. I do urine drug screen. I send it out for confirmatory testing. My patients know to expect that. But they also know that if they don't want to give a urine drug screen, they're going to have a conversation instead, and that it's a safe place. And by the end of the conversation, I don't need a urine drug screen to know what's going on with them. So the role is nuanced in the outpatient world as well, with the point never being punitive, and instead just being useful information.
That's a great point, Lonnie. We have just a few more minutes left. If anybody, there's an exit poll that popped up. If you wouldn't mind filling it out, super helpful feedback. And in the meantime, if you want to pop any last minute questions in the chat, or feel free to unmute yourself and ask.
Well, if there are no other questions, I just wanted to thank Ariana, Alicia, and Lonnie and Sarah for an incredible session. I'm still really processing all of it, and I was looking at the questions as they were coming through in the chat, and it seems like there's a lot of need. And I know Bill mentioned in Indianapolis specifically the need there, and it just sounds like it's going to be incredibly helpful for folks, especially with the news today, you know, about overdoses reaching, you know, that 100,000 threshold, over the 100,000 threshold, you know, from April in 2020 to April of this year. And obviously the pandemic was there, but I think this work was, you know, needed even before that. So, so again, really thankful for the time today from our California Bridge friends, and also for those that joined the line. I know we lost a few who had upcoming meetings. So yeah, please fill out the exit poll if you haven't already. We'll try to send a link in our email that we'll send out as follow-up as well. And I do see, are there any other questions in the chat? I really want to make sure everything gets addressed. Okay, it looks like we're good, perfect. Well, we'll go ahead and end the session. Again, thank you to our friends at California Bridge, appreciate it. And thank you to everyone for joining today. We hope everyone has a good rest of your day. Take care.
Thank you, everybody. That was very fun.